Hi guys. I hope you guys are doing great and that you are enjoying the content in the channel. Um, Please remember to comment, to like, and to share. By doing that, you'll be helping me a lot, and you'll be basically helping me to reach more people, more students, more interns, and and all those that might be interested in the content that is in the channel. So guys, I want us to talk about heart failure. I'm not really gonna talk about the diagnosis much and all of that, but I want to focus on the management. I believe that um, I don't think there's anything tricky about diagnosing heart failure, so I won't dwell much on that. But I know there's something tricky about managing heart failure, which is what I'm gonna talk about um, for the best part of this tutorial. So heart failure. So heart failure, how do we define heart failure? So heart failure basically is the inability of the heart to pump sufficient blood that caters for the metabolic needs of the body. So the heart is not meeting up with the metabolic demands of the body. So it's a pump failure problem. That's simply put, ne? So how is heart failure classified? I like these classifications. There's an anatomical classification. There is a symptom classification, and then there's a functionality classification. Under anatomical, heart failure can be left-sided, right-sided, or biventricular. The symptom classification of heart failure is by the New York Heart Association. It classifies heart failure into class 1, class 2, class 3, and class 4. When it comes to class 1 is basically a patient that is not showing any symptoms. So it's an asymptomatic patient that is still functional. They are still able to be active without getting any symptoms. The worst is class 4, whereby a patient is symptomatic even when they're just sitting. They get shortness of breath, and so these ones don't need, or they don't have to be active before they can experience symptoms. So they just experience them while they're just seated. And then anything in between would be class 2 and class 3. And I would recommend that you go and look at this. It would be very nice if we were able to pick up our patient when they are still class 1, when they've got heart failure but they're still asymptomatic. But we know majority of the people, they come when they're already sometimes class 3 or class 4. Functionality, how is it classified? So here they use the ejection fraction, and it's more of the left side, the left ventricle. So so here they use they look at the ejection fraction. Remember, heart failure is a cardiac output problem, or is an ejection problem. So the problem is the heart is not having enough cardiac output that satisfies the body needs, or the ejection. And the blood that is being ejected doesn't meet or doesn't satisfy the requirements, the metabolic demands of the body. So you've got heart failure. If you've got an ejection fraction that is more than 50, 50%. That heart failure is called heart failure with preserved ejection fraction. If your ejection fraction is less than 40%, it's called heart failure with a reduced ejection fraction. 41 to 49 is called heart failure with a mid-range ejection fraction. These are the most symptomatic. These patients are sick. I've seen patients with an ejection fraction of 30, of 28. So these patients are really, really sick. So it goes without saying, the higher your ejection fraction is, the less symptomatic you will be. So that's that. So briefly, guys, I just want you to go and look at this thing. I'm gonna just go do it very briefly. So if this is our heart and our ventricles, and these are our lungs. So left-sided heart failure, the problem here is congestion. You develop, because there's an inability to pump blood efficiently, so some of the blood, they remain inside even after an ejection has taken place. And when a lot of blood remains in here, with every ejection there's blood that remains here, you end up dilating this, it becomes big, and you develop high pressures here. These high pressures are gonna cause blood to be, are gonna cause sort of like a stasis kind of a thing, such that, and when you've got high pressures here, blood will always follow, will always go to a part that has got less resistance or less pressures. So you're gonna find blood that is gonna stay here. So you will dilate your ventricle, and then this stasis ends up building up in the lungs. So patients that have got a left-sided heart failure will present mainly with pulmonary symptoms, pulmonary signs and symptoms. They'll present with shortness of breath, orthopnea. They'll present with cough, clear sputum. They'll present with wheezing. You know, when they've got pulmonary edema, they'll also present with coarse crepitations. You know, a patient that has got heart failure but they are wheezing, that's called cardiac asthma. I know we know what bronchial asthma is. Bronchial asthma is narrowing of the bronchioles because of vasoconstriction, and you get a wheezing sound. But with cardiac asthma, your bronchioles are so edematous that the lumen has closed. Now the air is trying to force itself through that. So this cardiac asthma cannot be managed with bronchodilators. You need to give a patient diuretics because the problem is congestion of the lumen of your bronchioles. So those are the symptoms that they will present. On top of the fatigue, they will feel lethargic, sometimes headaches and dizziness, all those things. Generalized body weakness, all those things. So they will all have pulmonary symptoms mainly. But now if you've got a right-sided heart failure, so the same thing happens. You get blood here that cannot be ejected. So you always have, so with every ejection, you always have blood that remains behind. So that blood is not good because it keeps dilating this heart, such that you end up dilating your right atrium as well. And then you dilate your veins in the neck. So you get an increased JVP. And you also get, remember, the inferior vena cava. You also dilate that up until you cause congestion in the liver. They develop ascites, they get swelling of the legs, they get a splenomegaly, they get hemorrhoids, because basically we've got portal hypertension here. You get hemorrhoids, you get, so that's basically a right-sided heart failure. This is just like brave, guys, like brave. You know what they call PND, paroxysmal nocturnal dyspnea. When a patient is walking, majority of the blood stays in the legs. But when they start now to lie down, the blood that has been having difficulty getting back to the heart, it now starts to go back to the heart. And the heart doesn't cope with so much blood because it's a weak heart already because of the dilatation that has been happening here. So when you get that, the heart now gets, it becomes difficult for the heart to be able to cope with all the blood that is moving from the peripheries. And then the patient gets a dyspnea, and then they wake up. Now they get orthopnea. So they need now to get, they use a mattress, pillows to put at the back so that they don't lie flat, but they lie at an angle, cardiac position. So briefly, that's that. But this is not what I want to talk about. So we said that I want you to get me, brothers, friends, family, yes. I want you to get me because I don't want you to lose me here. We said that you have all of these symptoms because you've got a problematic cardiac output or an ejection fraction. So heart failure is, you've got a reduction here. So there's a reduction here. So the cardiac output is not enough to meet the metabolic demands of the body. So let's talk about, remember that. Now let's talk about, so when you have a decreased cardiac output because of the things that can cause a reduced cardiac output are things like severe vomiting, diarrhea, bleeding, pump failure problems like in heart failure, and other things as well. So anything that is going to cause you to lose fluids will potentially decrease your blood pressure and decrease your cardiac output. So once you've got a low cardiac output, the kidneys will pick that up that, hey, we are having hypoperfusion here because of a reduction in our cardiac output. So the kidney will try and correct that so that we get back to stasis, to homeostasis. So what the kidney will do is to release renin. Once renin is released, renin will convert angiotensin into angiotensin 1. This will convert, renin will convert angiotensinogen into angiotensin 1, and then an enzyme called ACE, angiotensin converting enzyme, will convert angiotensin 1 into angiotensin 2. Angiotensin 2 will go and act on the adrenal glands and cause them to secrete aldosterone. Aldosterone is gonna go to the collecting ducts in the kidney and cause reabsorption of sodium. Once you reabsorb sodium back to the body, water will follow. And once you keep doing that, your blood volume is gonna go up. And once you increase blood volume, your cardiac output will also normalize, will also go up as well. Listen to that. You've got a low cardiac output, and then we are starting to hypoperfuse the kidneys. The kidney will pick it up that I'm having a low pressure here. I'm not being perfused well. So it's gonna release renin, and the cascade is gonna continue because what the kidney wants to do is to have water. Because the way the kidney interprets this is like, okay, if I'm having a reduced cardiac output, it means I've got a problem with my blood volume. So let me correct the blood volume. That's why you get this step and then you end up releasing aldosterone, which will cause reabsorption of sodium. And because when you reabsorb sodium, water will follow. And if water will follow, when water follows, you get an increase in your blood volume because now you are peeing less. So there's less urine formation because you are taking all the water that is supposed to be coming out as urine. So you take that water back to the system, and then now your blood volume goes up. When blood volume goes up, your BP goes up. Remember, BP is equals to cardiac output times PR. So once you increase blood volume, you increase blood pressure and you increase cardiac output. So this guy now normalizes. When that thing, when the cardiac output normalizes, then this system is called the rest system, right? The rest system will now be deactivated. Now the body's gonna be like, okay, we've got enough. So once cardiac output goes up, then the renin stops being secreted. This is well, it's fine, it's superb, it's beautiful when you don't have heart failure. But now when you have heart failure, this is the problem. This is fine, it's normal physiology, it's nice, a nice physiology for a heart that is normal. But problems start to begin when now you have a reduced cardiac output because of a pump failure problem. When you have a reduced cardiac output, remember in heart failure, your heart muscles, your ventricles are dilated, are big, they are floppy, they are not effective. So that's why you are having a reduced cardiac output, because you've got a pump failure problem, even though the system is overloaded with fluid. So you don't have a problem with fluid, you do have water in your body, but now you've got congestion. So the heart will, the kidneys are going to say, okay, if I'm having reduced cardiac output, the same thing is going to happen, the cascade. Renin will be released, angiotensin is going to be converted to angiotensin 1 into 2, and then you get aldosterone release. The problem with this system for heart, rest system is bad. Rest system is bad for a heart failure. It's very horrible. This is the reason. So the kidney is going to say, okay, I'm hypoperfused, so what should I do? Let me release renin. But when you do that, you end up the same way. You end up absorbing sodium, and as you absorb sodium, water will get back to the system. Remember, in heart failure, you've got fluid overload, and the more you take water from there, you want a heart failure patient to pee. That's what you want. But this system is causing, is against that. It works against that. You want a heart failure patient to pee so that they don't become fluid overloaded. You take out the fluid from their legs, take out the fluid from their lungs, take out the fluid from their liver, from their abdomen, and all those things. So that's what you want. You want to take water out of the system. That's what you want. But the rest system is doing the opposite. It wants to, because, so it takes back sodium and water. Once you do this, you are overloading a system that is already overloaded. So your heart failure becomes worse and worse and worse and worse. So the rest system is horrible for heart failure. Remember, another thing that happens, this angiotensin 2, it also goes and acts on the systemic vessels and cause vasoconstriction. Those are the two things that it does. It causes the aldosterone to be released, and it also causes vasoconstriction. This vasoconstriction is basically, it increases afterload. Please go and read, go and look at the video that I posted about antihypertensives. When you increase, when you cause vasoconstriction, you increase afterload. And afterload is bad for a failing heart, because when you've got an increased afterload, it means you are saying to the heart, you must work harder so that you can have effective cardiac output or effective ejection fraction. So a heart that is already floppy, that is already weak, you are saying to it, it must work harder because you have increased your afterload. That's what the rest system does. It makes the heart to work harder because of this vasoconstriction that it causes. And remember, when you've got an increased afterload, it means the heart must overcome that afterload in order to have an effective or a significant cardiac output. But this heart is already floppy, so what is it going to do? It's going to try and overcome that afterload so that it can pump effectively. But in the process, it dilates and becomes bigger and bigger and more floppier. So this is why the rest system is horrible. Vasoconstriction that it causes, and this water reabsorption that it causes. So when you give heart failure patients an ACE inhibitor, you come and block this enzyme here so that angiotensin 1 does not get converted to angiotensin 2. So you block this, and once you block this enzyme here, then you won't have these effects. And that's what you want in a heart failure patient. You want to give them the angiotensin converting enzyme so that they don't, remember, when you have an afterload, if you increase, let's say this is a heart cell, a cardiomyocyte, you have heart failure already. So if you increase afterload because of the vasoconstriction that is caused by angiotensin 2, you are forcing this heart to become bigger and bigger so that it can cope with the afterload that you have just exposed it to. So it's going to become bigger and floppier up until it's very weak that it cannot even eject more than 50. So the ejection fraction is gonna become more floppier and less effective. And also the water that you bring in is gonna cause it to dilate more because it wants to take out that water that you have increased in the system because of this rest system. So these two are working against heart failure. These two. Hence, it's important to give a patient. Remember, when the cardiomyocytes become bigger and bigger and bigger and bigger, trying to cope with the fluid overload that is in the body and to pump effectively, they become fibrotic, and that's called remodeling. So you get cardiomyocytes that have remodeled, they become fibrotic. A fibrotic thing cannot be elastic. So these drugs, the ACE inhibitors, they make sure that that doesn't happen. So they are the only drugs that have been proven that they help with because you don't want remodeling. So this kind of delays or stop the remodeling of the heart because you don't want remodeling. You don't want, because if you have got remodeling, you're going to have a heart that is just fibrotic. Everything is fibrotic, and a fibrotic tissue cannot be elastic. So that's why ACE inhibitors are amongst the anti-failure treatment. They are called the anti-failure treatment. Remember, when you are managing a heart failure patient, giving them diuretics, you are just helping them with symptoms, but not the heart failure. You are just helping them to feel better. It's like giving them digoxin. You are just helping them to feel better with your diuretics. But in terms of the ongoing damage that is at the level of that is at the cellular level, you are not doing anything about it. So heart failure patients must be on anti-failure treatment, and there are two classes of drugs that have been proven to be anti-failure. It's your ACE inhibitors and your beta blockers. And a beta blocker of choice there is carvedilol. So this is part one, guys. This is part one of the heart failure. We are gonna continue. So you don't want, remember, you don't want the rest system to be, in heart failure, you've got a chronic, because you've got a chronic reduction in your cardiac output. So you've got a chronic activation of the rest system, which keeps doing these two things that we don't want. So it's a chronic, because the cardiac output that is reduced in heart failure is a chronic thing. So this causes a chronic activation of the rest system. So to shut the rest system down, you block it. You use ACE inhibitors. We can use ACE inhibitors of choice: enalapril, captopril, perindopril. The most commonly used one now is your lisinopril. So you can use those drugs to make sure that, and studies have shown that once you deal with the rest system properly, you might even need to reduce your diuretics. That's how effective they are. Because if you're not retaining water in your body, because this one makes you to retain water, and you want, so if you give, and you want to take out the water, so if you give diuretics, right now the patient will feel better because you are diuresing them, so they are losing fluids. But once they go home, because the rest system is continuously working, it keeps reabsorbing water and also causing vasoconstriction. So patients that have got heart failure must be on ACE inhibitors and beta blockers, and preferably a carvedilol. So we're gonna do part 2 of heart failure. Part 2 of heart failure. Thank you so much for watching. Thank you, and thank you.